A warm welcome to all people who have joined. And thank you and congratulations for joining, Manyata. Today we will going to discuss a very, very critical issue, that is intrapartum fetal monitoring. Once again, welcome to Manyata, and it has been a great journey with all the associations. We have learned together a lot, and what we are today, it is all association and learning from each other, and it is all what life about. With this, today when the medical fraternity is really going through a very rough phase, I bring greeting from land of Buddha and land of Rama and land of ascetic yogi Gorakshnath, and we have to obtain peace in ourselves so that our outer world can be peaceful. So I will just start one note on it. When we are doing intrapartum fetal monitoring and valuing the small life which is going to come, it is very important that as a medical organization, as a medical fraternity, we appeal to everyone that we have to value the adult life also and all the dignity for which we are bringing the new lives into the world. So with this note, what Dr. Hema has said, like it was her video message, but we are on the same tone and at the same note that to acquire knowledge, one must study, but to achieve wisdom, one must observe. So woman has been delivering babies since creation, but the labor management has drastically changed with change in civilization, technology, as well as the people's expectation from the obstetrical healthcare provider. So a lot of world about that we are doing a lot of medicinalization of human labor. There should be more humanization of human labor, but important thing is that we have to make the balance of all the two. And there are very few areas of clinical obstetrics who have commanded that much of attention, that is the assessment of fetal well-being during labor, which nature and God has designed the most difficult journey of a human life when the baby passes through the maternal pelvis. Beside this, there has been the contemporary advances in ultrasound. There has been a question as well as the applaud for the availability of cesarean section, the women who need, and a lot of compelling professional liability. Last session we had on the medical legal issues. So there is a lot of compelling professional liability, a little like fear of the getting sued is hanging on the obstetrician's mind. So for all these repercussions, there is echo and strong voice. So there is always a people want a balance, that is humanization of childbirth vis-a-vis medicinalization of human labor. And today when the world is too much connected and too much informed, the making balance in our obstetrical practice is a very critical issue which we learned over the years. So it is a paradox of modern society that human condition is becoming more and more sophisticated, planned, but the ability to give birth, especially the vaginal birth, has remains fraught with imperfection. But if we have a good monitoring tool for the mother as well as fetus by human resources, by technology, we can detect and promptly manage a lot of complication which can develop during labor. And we will discuss what are the recommendations made by different professional bodies, our own Manyata program, as well as the government of India. So it remains a dilemma, and this is something very important before we go into the intricacies of means of fetal monitoring, that we are losing around 2.6 to 3.2 million babies. They are having stillbirth. 98% of these are found in developing countries. India contributing to top of stillbirth, around 592,100 stillbirth just in last 3 or 4 years back. And intrapartum, out of all these stillbirth, intrapartum stillbirth is one of the major cause of stillbirth in not only in India, but whole region of South Asia. So this is very important that the Manyata is propagating the fetal monitoring, good fetal monitoring. So what is the basics of fetal monitoring in labor? That the mother and fetus are under great deal of stress throughout the labor. fetus is particularly sensitive to maternal intrauterine environment, and when there are uterine contractions, the fetal reactions to various stimuli may reveal important detail about its health. So when there is an earliest stage of oxygen shortage in arterial blood, it is hypoxemia. If it is not treated, then it results into the hypoxia, that is oxygen depletes peripheral tissue. If it is not taken care, then it is a asphyxia. And then the fetal organs like heart, lung, kidney, liver, and gut, they go on to the anaerobic metabolism and when oxygen level drops. So it is very important that we have an accurate fetal examination and diagnosis during labor because it gives us insight into the health of the fetus. So what we understand with the fetal heart rate as well as the CTG, that it is a crucial relationship between fetal heart rate and its states with the change of time and environment. So autonomic nervous system control heart rate dynamics by controlling sympathetic and parasympathetic impulse to heart in opposing ways. And in response to danger, sympathetic nervous system levers up the body while the parasympathetic nervous system regulates heart reaction and help body to relax. So we are actually studying the heart rate, but it is showing the fetal nervous system what is happening. So how do we monitor the fetal monitoring? It is fetal heart rate abnormality. If it is a meconium stained liquor or it is a cord prolapse, this is the sign that the fetus is having stress. So we have few things for our means, that is the stethoscope, we have the hand-head Dopplers, and we have the cardiotopography, that is non-invasive and invasive. So the CTG does not, it is very important that the cardiotopography does not directly prevent pregnancy complication, but it plays a crucial role in monitoring fetal well-being and identifying fetus as risk of hypoxemia. So it can be non-invasive fetal CTG, invasive, like we are having external monitoring, and it can be interpreted by us, by our staffs, by our clinician, as well as the artificial intelligence or the machine learning, what Dr. Hema Divakar was telling. So this is very, again, important that the government of India have got guidelines for the Indian setup and the FOXY Manyata clinical standard. They mentioned that in intrapartum fetal recording, we must have the recording of fetal heart rate at regular interval in first and second stage of labor for the reasons that the intrapartum stillbirth and intrapartum birth asphyxia contributing to a lot of perinatal morbidity and the mortality. The Indian scenario, we have a different level of healthcare system, the tier 1 primary health center, small nursing home where we have the internal auscultation available. Maybe cesarean delivery facility may or may not be present. It can be the tier 2 district hospital private nursing home where we have the Dopton CTG machine facility for cesarean section. The other fetal blood sampling, which is a question mark, not available, and tier 3 tertiary care center or the corporate hospital where we have all the facilities. And that's why in India, we have the different recommendation, and the FIGO also have the different recommendation. But what we want to achieve by all recommendation, that we want to have the improvement of intrapartum fetal monitoring throughout the world, and thus reducing burden of perinatal mortality and long-term sequel. So we want to have a healthy next generation. So this is very, very important. So what is the scope of all these Manyata training and Manyata as like all understanding that how we should record, how frequently we should record, because we want to have the good capacity building the human resources. So in Manyata, we have been reaching to all over the country, like Chhattisgarh, Jharkhand, UP, all state we are doing the virtual program. And this actually makes the important issue that the human resources, the human people, the nurses, our resident doctor, they are capable for doing the good intrapartum monitoring. And it is very, very important that when we have the CTG machine, it should not be regarded as a substitute for good clinical observation and judgment or as an excuse for leaving mother unattended. So birth companion is something which we are calling on Manyata, respectful maternity care. So this become the intrapartum fetal monitoring become the integral part of all the labor management. So intermittent auscultation is the simplest form of assessment of fetal heart rate. It can be done by the fetal Dopton or a good quality stethoscope. And what is the recommendation? This is very important. In first stage of labor, this should occur at least every 15 minutes after uterine contraction and for minimum of 60 seconds. In second stage of labor, when the patient is having the almost 9 to 10 centimeter cervical dilatation, intermittent auscultation should occur every 5 minutes after a contraction and for minimum of 60 seconds. However, when the low risk situation, it can be a little flexible. That is in first stage of labor, every 30 minutes and every 15 minutes in second stage of labor. And how it is a low risk on the patient need very frequent fetal heart auscultation. This is the clinical perspective which every paramedical and every resident and healthcare provider should know. So intermittent auscultation, it is important that if the patient is having induction of labor by any oxytocin drug, if patient is having epidural anesthesia, we have to have a very good frequent intrapartum fetal intermittent auscultation. It has to be documented on partogram with the judicious record. So it is in Manyata, we are training the people how to feel the fetal heart rate on the partogram and how to act on it, which we will just discuss in a few minutes. So this is very important observation that the intermittent auscultation actually, if it is done properly, it reduces the cesarean section rate and it does not adversely affect any perinatal mortality or the risk of cerebral palsy. So this is something very important, and even the Western world also says that the intermittent auscultation is a very good mean in the low risk population and intermittent. But if you find that there is any abnormalities into the intermittent auscultation, like you are having the fetal tachycardia or bradycardia, or there is any evidence of any deceleration, then it should be changed to the continuous accorded topography. So this is very important that how frequently we do. We understand low risk and high risk situation. We identify any abnormality on intermittent auscultation or by the handheld Dopton and switch over to the CTG whenever it is needed. So it is a simple thing. It is available. Stethoscope and handheld Dopton is available in almost all settings. It is non-interventional approach. There must be the nurse to patient ratio around 1:1, which may not be present sometime, but actually our nurses can make so experienced and they can be made so knowledgeable that they can handle around 1:3 patient also. But of course, the human errors and the training period is important for the various reasons. And the limitation is that it does not allow for assessment of variability or the periodic changes. So coming with after internal auscultation, we have the CTG, which was evolved in 1970. And it was shown that the fetal heart rate pattern actually correspond to fetal acidemia. And we can utilize this technology for the intrapartum fetal monitoring. The negative predictive value of the CTG is very, very high, because if it is good, we can say that this fetus is fine, but the positive predictive value is a little bit compromised. So the antepartum and intrapartum risk factor, if there are any antepartum or intrapartum risk factor, oligohydramnios, preeclampsia, gestational hypertension, it requires continuous electronic fetal monitoring. If there has been the bad obstetrical history, they are the candidate for the CTG. And it is also recommended when you find any abnormality on the intermittent auscultation. So indication of CTG in our setting, and many of the Manyata facilities are the NABH approved also, and they are having a lot of high risk obstetrical patients. And these patients who are having preeclampsia, gestational hypertension, gestational diabetes mellitus, or high risk fetus, ultrasound diagnosed IUGR, liquor abnormalities, any past obstetrical history, or she has any obstetrical intervention like epidural anesthesia, induction, or any abnormalities during intermittent auscultation. These are the candidates that they should be subjected to the cardiotopography. It is important how you take the position. So lateral recommend half sitting and upright position is important. See that the sensor is well placed at the right time. Paper speed is usually 1 centimeter per minute, because if we increase this paper 2 and 3 centimeter per minute, it takes the longer time and a longer length of the printing. And always document the patient date and time with duly signed by staff at the end of delivery. So for medical legal issues, it is very important that it should be documented that up to what date and up to what time this patient had the normal CTG, and if it was abnormal, what action was taken. External monitoring is done in our most of the Indian setting. Internal monitoring is costly, invasive, and had a specific contraindication if the patient is having any infection or any complication like fetal injury or bleeding. In Indian setting, most of our facilities, we are using the external monitoring. So interpretation of the CTG with this a good position, good speed, good machine, and the good clinical background. What are the steps? One is the clinical setting. You have to interpret the CTG as per the gestational age, antenatal event, previous CTG tracing. Step 2, what is the current clinical situation? Like she has been induced or she is having epidural. What is the indication for CTG? What is high risk factor? What is the set limit step? What is the speed and access the trace? What is the identified risk? What is contraction? And what is the pattern of tracing? So Dr. C. Bravado is what we are using for the interpretation of CTG. So DR, determine risk. C for uterine contraction, BRA for the baseline rates, B for variability, acceleration, deceleration, and overall assessment. So this Dr. C. Bravado mnemonic actually reminds you that you don't miss any part of the CTG and you read the CTG very well. And this reading between the lines, that what you are reading and what you are interpreting for CTG is very, very important. And Dr. C. Bravado actually reminds our every step what we have to look very, very carefully. Every CTG reading can be classified as normal when all 4 features are classified reassuring. Suspicious when there is one feature classified as non-reassuring and remaining feature as reassuring. Pathological when there are 2 or more features classified as non-reassuring or 1 or more classified as abnormal. So communication between staff should convey the clinical context and use of consistent terminology to describe feature of CTG, what is the level of concern and urgency of situation. So this is very important that when we understand, when we are interpreting CTG, we have the good communication and we understand what does it mean and what we have to do. So it is a red, green, blue. So it is green if it is a fetal heart rate between 110 to 160, variability more than 5, no deceleration and acceleration present. It is almost 99% that the fetus is fine. Suspicious when it is 100 to 109 or 161 to 80, less than 5 variability. We have the typical deceleration and there is no acceleration. And pathological, which need a close and the urgent attention if fetal heart rate is less than 100 or more than 180, if it is sinusoidal pattern which persists for 10 minutes, variability less than 5 for 90 minutes, and you are having the atypical variable deceleration for most of the time. So variability, acceleration, deceleration, what is early, variable, late. So this is a long thing, and we always teach how to read with this. The variable is a V shape, which starts with the contraction and which finishes, but late is the U shape, which start around 20 seconds after onset of contraction, have a nadir, and return to baseline only after end of contraction, and prolonged deceleration, which is lasting for more than 3 minutes. So whenever you find that there is a suspicious, there is a yellow light issues, you have 1 or 2 non-reassuring feature, check the CTG machine, check the setting, and review again the clinical background. That if the patient is having any temperature, if the patient is giving any tocolytic, so it can result into the tachycardia. It is not recording the maternal pulse and the other maternal factor, like mother is having hypotension, is she have ruptured the membrane, so there is a sudden fetal heart rate abnormality, it is cord prolapse or something. So this is important, and because whenever it can change, so you have to continue the monitoring for the next 20 to 30 minutes, and again you have to read all the things, all the see revenue, that is rate, variation, acceleration, deceleration, with a very careful interpretation. And these are few pictures which show sinusoidal pattern, what is meant by the early deceleration and what is meant by the late deceleration. So with this intermittent auscultation, with this CTG, good machine setting, good indication and good interpretation, what we do next. And this is the thing what we are training our paramedicals, that what you should do. It is not like it is a just the variable deceleration in the real second stage and you go to the cesarean section. It is not so. You have to resuscitate the baby and do the urgent action. So if the patient has been given oxytocin, stop infusion. Sometimes the patient needs the tocolysis, so we must have some tocolytic policy about it. Change maternal position, stop mother to push if the patient is close to second stage. Rapid fluid administration if the patient is having epidural anesthesia. Sometime maternal oxygen, but it has not been found the effective thing. So this is something what we have to respond to it. When it is a suspicious, start with this thing, IV fluid, changing the position, stopping the maternal pushing, stopping the oxytocin agent, and see that the patient is getting the reversal of the CTG to the normal. But if it does not revert and the patient continue to deteriorate, consider need to be given for further evaluation or rapid delivery. It may be assisted vaginal delivery if she is in second stage. It may be cesarean section if it is not going to, the assessment says that the patient is not going to deliver soon. So the right action is very, very important. And again, we should be aware that there is a considerable inter-observer variation. It has a very good negative predictive value, but the positive predictive value is a little less than the negative predictive value. And we have to study the whole clinical profile, review the clinical setup, review the what is the status of the mother pelvis, the fetal head, what is the associated other feature, and do the necessary action. So this is a very important study because we have the doctors in audience. So this is something to be shared, that with the continuous CTG, if we apply very regularly, there is an increase in cesarean section as well as the assisted vaginal delivery, and only a less reduction of the perinatal complication. So intermittent auscultation with the good frequency, with the good technical person who is the having the experience of good monitoring and listening to the fetal heart during labor, it really a very, very good method for the intrapartum fetal monitoring. I will just touch on the other method, fetal blood sampling, which is actually not done throughout the world, not in India. So the contraindication there are, of course, it is a severe fetal compromise, bleeding disorder, infection, prematurity phase presentation. But the studies actually says that it is not a very effective means for the fetal monitoring because the false positive and false negative reports are very high. So it is now uncommonly used, and we are not actually advocating just to be averse, because we have a lot of very good like all gynecologists in our audience, and the fetal pulse oximetry, which actually registers the oxygen saturation, and what is normal, it is 30%. So it is also has not been found very effective in a real the studies. And the stand, which is the fetal CTG as well as the fetal ECG, and the many studies again shows that this has no benefit on neonatal or obstetric outcome. So it is the mechanical machine learning or the artificial intelligence, which Dr. Hema was saying. And these are few good papers who says that the inter-observer and intra-observer variation that has been really tackled with the use of artificial intelligence, and it underscores that in future time it may be a very good tool to assess, and we can we can minimize the error which has been done by the inter-observer, intra-observer variation and interpretation of the various CTG findings. However, we have to learn and understanding, because artificial intelligence also has to be learned and to be taken into our like a learning process. So it is finally the human mind, finally it is a genuine intelligence which reads the even artificial intelligence. But it will be the way ahead, and how with what wisdom we inculcate this artificial intelligence in our armamentarium, it is the future time will say. So this is the final, the simple thing is the best. So intermittent auscultation is for every setting, but if it is high risk, it is better to go for the CTG. The frequency should be 30 minutes and 15 minutes in first stage. If it is a low risk, and second stage, 15 minutes and 5 minutes. So these are the key recommendation, that you standard structured intermittent auscultation is very good for low risk. In moderate to high risk, CTG is good, and always feed the placental fetal perfusion through intrauterine resuscitation before proceeding to immediate delivery for all category, second and third dressing. So this is important. And finally, it is not only the machine, it is not only the observation, the always the medicine is all about the compassionate care, all about the wisdom. And Manyata is the our aim, which is our around 13 years experience with Manyata, that when we connect to our labor room staff who is taking care of 12 hours and the 18 hours and 24 hours in the labor, this is the regular and structured training of labor board, which actually labor staff, which is ensure the proper use of technology. And Manyata stand for this principle. So I request everybody to, you are the leader of Manyata, propagate the Manyata so that we can have the advantage of this Foxy Manyata leadership into the all remote places, to all secluded places, as well as in the big cities where there is a real issue for caring for the labor patient. So finally, the small wisdom is like water in a glass, clear, transparent, pure. The great wisdom is like the water in the sea, dark, mysterious, and impenetrable. So hope that you have enjoyed this vast wisdom, that how we understand the fetal language and fetal call for help them out in a right way, and optimize the way of delivery. Thank you very much for the patient listening, and thank you for the opportunity.